Thank you. I think those set me up for disappointment. But anyway, I'm amped up on coffee. If I rush through this, please slow me down, okay? But again, my pleasure. I'm really honored to be here to talk about such an important subject, to hear from some of our very thoughtful leaders here and from our neighboring institutions. So we're going to specifically talk about heart failure with preserved ejection fraction. We'll leave heart failure with reduced ejection fraction to another time and another talk, and mainly in advanced heart failure. But we're going to define what HFpEF is according to the new kind of recommendations, and then we'll sort of also subtype what HFpEF with pulmonary hypertension looks like hemodynamically. We'll talk about epidemiology and pathophysiology. We'll get into the current treatment strategies, not from a pulmonary vasodilator standpoint, but just from a medical therapy standpoint that we do for heart failure, although we are limited. There are a couple of things with some interesting observations. And then we'll talk about what I think most people are interested in hearing is the use of pulmonary vasodilators in this special population. And then we'll talk about future directions. So who is HFpEF, what is HFpEF, and what is HFpEF with PH? I think all these acronyms give me a little dizzy sometimes, but I think it's important to understand the patient population that we're talking about. So according to the new universal definition and classification of heart failure, which was just published this year, I would recommend perusing that when you're on a beach. HFpEF is defined as a left ventricular ejection fraction greater than 50%. You're going to have signs and symptoms of congestive heart failure, and you're going to be plus minus biomarkers, as we know that sometimes with certain body habitus and things like that, they may not have positive BNP, NT-proBNPs. When we talk about pulmonary hypertension and left heart disease, we're talking about specifically isolated postcapillary pulmonary hypertension, where you have a mean pulmonary artery pressure of greater than 20, a pulmonary capillary wedge pressure of greater than 15, and a pulmonary vascular resistance of less than 3 Wood units. When we have combined pre- and post-capillary pH, which I think this is a special population that gives us some issues as well as nightmares, these are the patients who have a mean pulmonary artery pressure greater than 20, our pulmonary capillary wedge pressure greater than 15, and a pulmonary vascular resistance of greater than 3 Wood units. So why are we seeing this more? Well, I think in general, HFpEF, when you look at trends, the prevalence is actually increasing. And why is that? Well, our aging population. We see this more in patients who are older as they get older than the age of 65 and 70. And you can see here on the left, this is a, I don't have a pointer, but if you look on the left, if you look at trends, you see that in the red you have heart failure with reduced ejection fraction kind of stabilizing out over the past decade, and this is a prospective study that was done back with the guidelines, and the predicted prevalence of HFpEF was increasing in our inpatient population. And this is kind of seen also in Europe, looking at southwestern Europe, looking at the age of the prevalence of heart failure with preserved ejection fraction going up as their age increases, specifically in female patients versus male patients, whereas you see the prevalence staying stagnant really for heart failure with reduced ejection fraction on that right-hand side. And we're seeing this in the inpatient side as well, and I think this is where we see these sick HFpEF patients with recurrent volume overload, CKD, and you can see over the years that the actual incidence of heart failure with preserved ejection fraction on the inpatient side has been rising over time to the point where you're almost seeing a 50-50 split with heart failure with reduced ejection fraction and the kind of the unspecified heart failure diagnoses. So something we're seeing more and more every day, and I'm sure you guys are feeling this more and more every day when you see patients in clinic. So in my mind, and we'll talk briefly about phenotyping, HFpEF has been specifically challenging because in heart failure and cardiology in general, I think we took the approach of using the same modalities of therapy that we did in heart failure with reduced ejection fraction. I think for the most part, we thought putting beta blockers, ACE, ARB, ARNI, MRAs, all would have this beneficial effect of improving symptoms, reducing hospitalizations, improving mortality. And we haven't seen that in these large randomized control trials that we've done in these subgroup of medications. And this is work out of Northwestern, and I think this is Sanjeeb Shah, who was one of the first to really notice this trend is in his own clinic of heart failure patients at Northwestern with preserved ejection fraction, he noticed that not every patient was the same. So when he took a look back retrospectively at about 400 to 450 patients in his clinic, he noticed that not everyone was the same, and they found 3 distinct phenotypes using machine learning, and they saw that they had 3 specific groups. And we'll focus on group 3 because I think this has been pervasive in a couple of other studies that were done subsequently. But you had this group 1 phenotype where you had these very younger patients, obese, not really having a ton of cardiac remodeling on their echocardiogram, and not having a significant BNP elevation. You had group 2 where you had a little bit of cardiometabolic obesity phenotype, impaired relaxation, high prevalence of diabetes. And then this third phenotype, which was probably the most problematic and most concerning, is where they had pulmonary hypertension, RV failure. And they saw that these patients with pulmonary hypertension, RV failure, and cardiorenal syndrome had the worst outcomes over time when you look at the Kaplan-Meier curves on the right. So what's really happening during this time? Well, I think we have an understanding that this is all starting from some type of event causing vascular stiffening, myocardial stiffening, and fibrosis, which leads to abnormal relaxation, chronically elevated left atrial pressures that are going back into the pulmonary vasculature, causing that pulmonary hypertension, initially being post-capillary, and then with ongoing remodeling of the vasculature, microvasculature and microvenules, you'll see this sort of combine into this pre- and post-capillary pH. And you see that on the right, it's a nice diagram sort of looking at this kind of circular kind of movement as this kind of keeps going around and around in circles. So what does this look hemodynamically? And this was a study done out of Mayo Clinic where they looked at all different phenotypes of patients with heart failure with preserved ejection fraction, normal PA pressures, isolated post-capillary, and the combined pre- and post-capillary pH. Now bear with me, I know these graphs look a little small, but we'll try to walk through this. And if you can see on the top left-hand corner, the dashed lines, which is the lower line that you see, is your exercise work and your cardiac output for that work. And you can appreciate the patients who had the solid red line and black line, the black line being your normative, your control patients, and then you had your isolated post-capillary pH patients in the solid red, that they had higher cardiac outputs for work that was being done, where you don't see that same increase in the combined pre- and post-capillary pH. You go to the little box in B, and still in that left-hand figure, you see a steeper increase in your pulmonary capillary wedge pressure, which is on your y-axis, per cardiac output on your x-axis. And overall, you see just a poor sort of cardiac response to exercise. When you get to the other graphs, you start getting the story of worsening pulmonary hypertension with exercise. They have a steeper increase in their mean PA pressure. They have less left ventricular transmural wall pressure, and that is thought to be related to this kind of RV-PA uncoupling and underfilling of the LV in some of these severely sick patients. So overall, you see a patient that has an inability to exercise, inability to augment their hemodynamics appropriately with exercise, leading to this very severe phenotype that we see. So quickly, we'll go into current treatments. So I wanted to first talk about what we can do and have some data for. So for these patients, a lot of these patients have recurrent hospitalizations, and sometimes cardiomems can be appropriate in the right patient in terms of reducing and targeting a PA diastolic pressure, somewhat correlating with wedge pressure, and keeping them out of the hospital. With that, you can also see how your PA pressures are changing with therapy as you're sort of adding other medications, which we'll go into later. Exercise and weight loss can be very effective. Some of these patients are sick for some type of weight loss procedure, but rapid weight loss and the degree of weight loss does reflect in hemodynamics as well. So you see a rapid change in right atrial pressure, a decrease in wedge pressure, a decrease in pulmonary artery pressure as well, without a significant decrease in stroke volume. So weight loss, and especially our obese patients, can be very therapeutic in helping patients feel better. When we talk about TOPCAT, this was the trial looking at spironolactone at all comers with heart failure with preserved ejection fraction. When they actually did phenotyping in this, and this is actually from one of our colleagues, Dr. Tang, in conjunction with UT Southwestern, they also saw a distinct phenotype. So in the original trial, save for some parts of some of the centers that were participating, there was overall a possible reduction in hospitalizations with the use of spironolactone. When they actually looked at the different patients in there, they saw that there was a distinct phenotype that might have responded a little bit better to spironolactone, and this was the ones who had higher BUNs, lower EGFRs, were anemic, higher pro-BNP, NT-BNP levels, and had cardiac remodeling on their echocardiogram, including a higher peak TR velocity indicating pulmonary hypertension. When we look at SGLT2 inhibitors, this is probably the most exciting part of heart failure with preserved ejection fraction recently, with 2 now large randomized control trials showing improvements in reduction in hospitalizations, but also improvement in quality of life. Empagliflozin and dapagliflozin has been recently shown to be very beneficial. But what does that do for the pulmonary pressures? This was a small study out of Kansas where they looked at SGLT2 inhibitors and pulmonary hypertension as a single center randomized control trial, and they gave one arm SGLT2 inhibitors, one arm the placebo, and they looked at PA pressures over time. Now this was a small subset of patients, 93 patients. By the time they randomized, it was only 60, so we're not talking a large cohort, and there was, I think, a third to 40% that was actually heart failure with reduced ejection fraction, but they did see a correlation where you actually reduce your PAD over time without touching your diuretics and even coming down on your loop diuretic dosing. So there is some thought that SGLT2s might have some beneficial effect in the pulmonary vasculature this way in heart failure patients. When we look at ARNIs, sacubitril valsartan, aka Entresto, the Paragon HF showed a little disappointingly, but did have a signal toward a reduction in hospitalizations, maybe not a change in KCCQ or symptom burden, but in patients who had significant pulmonary hypertension, small subset, this was a small study that was done, 14 patients in 2 different studies, showing over time via cardiomems and right heart cath that you actually can see a decrease in mean pulmonary artery pressure, wedge pressure, without changing cardiac output. So some signals that, even though these aren't robust data by any means, might have some benefit in your normal armamentarium of medications that you can use for this sick patient population. So I think the crux that everybody gets, confused about is when to use pulmonary vasodilators, and unfortunately I can't give you a prescriptive answer for this, but I can show you what's been done already. And I think initially there was a lot of hope around pulmonary vasodilators based on some of the data out of Milan. This is a single center study looking at sildenafil and a single center randomized control trial, and their study was actually pretty remarkable, looking at mean PA pressures and PVRs greater than 3 Wood units, showing a reduction in both right atrial and pulmonary capillary wedge pressures, almost normalizing, which is not sort of thought would happen if you're using a PD5 inhibitor in HFpEF. So this was, and improving stroke volume, RV function, et cetera. So this was very, very promising, but it hasn't borne out in a lot of the studies that's been done. And there's been multiple studies looking at sildenafil, looking at ERAs, what have you, without much in terms of outcomes. Again, these are very small randomized control trials, multi-center, but looking at things like bosentan with high PVRs, no change in 6-minute walk tests, no changes in overall symptom scores. Relax, which just looked at echocardiographic data of pH, so didn't really get invasive hemodynamics. They just gave it to everybody, showing no benefit that way. Dynamic recently published using riociguat up to 1.5 milligrams TID. Their main outcome was looking at cardiac outputs, which did increase, but and the PVR did come down, but there was no change in how people felt or 6-minute walk tests, and a fairly differential in dropout based on side effects of the medication. Melody looked at macitentan. Again, small study, 63 patients, and what they found is the PVR did come down, but patients were presenting more with volume overload. And then Vitality looking at vericiguat, again, very akin to what Relax did, looking at just echocardiographic data of HFpEF. Didn't see any changes in KCCQ, albeit a larger randomized control trial at 789. So I think the jury's still out. I think if you look at this data, it's very pessimistic on how we use it. I think all of us have different kind of thresholds of comfort using these medications, specifically PD5 inhibitors in the patient without a proportion pH. But again, there hasn't been any data to really bear this out to show benefit in our patient population. So I think this still needs to be studied in a very systematic and larger way. And then quickly, we'll talk about future directions. And I think there's a little bit of a shift from just looking at pulmonary vasodilators to really getting at the underlying pathophysiology that's going on in patients with heart failure with preserved ejection fraction, looking at inflammatory and fibrotic pathways and seeing if you can target these as a way of reversing and improving pulmonary hypertension in these patients. There is some use of using beta-adrenergic stimulation to improve exercise capacity. And I think there needs to be better differentiation over patients who can and who won't respond to medical therapy, and I think we still don't have that data. So in summary, HFpEF, the prevalence continues to increase. This is going to be something that we all see in clinic, no matter what specialty we are. This is a complex, multi-system organ dysfunction pathophysiology. The evidence-based treatment and efficacy is limited, and even in pulmonary vasodilators, even more limited. I think we still need better studies to understand how to use these, especially for all our PH patients with HFpEF. And then future directions, I think clinical trials using phenomapping and precision medicine are going to be key. I think we realize that you can't lump all these patients together, all very distinct, and we have to figure out which groups are going to benefit from what. So thank you for your time. Happy to take questions.
Thank you, Sean. That was an amazing presentation, and I think we do have, we have 7 minutes, so I'll take any questions from the audience for Dr. Bhattacharya.
I have a question. Sean, when do you start pH therapies in group 2 patients?
It's incredibly tough, and I think, when we see these patients in heart failure clinic, Dr. Jacob and I think we individualize it as best because we don't have much to guide us. So I think it's the patients who are still limited functionally. They have PVRs that are greater than 5 that haven't been optimized on medical therapy. I still believe in using MRIs, SGLT2 inhibitors, if anything, for the CKD benefit as well as the HFpEF benefit, as well as ARNIs if they can tolerate it. Tolerability of ARNIs have been tough in some patients, even if they have PH. And then after that, it's if they're still limited in a 6-minute walk test, then I do trial these medications. I am very cautious. I don't go above 20 milligrams of sildenafil, and sildenafil is typically the only drug I'll use in this case. I think, we were sort of discussing before, but I think it has to go with the clinical scenario too. So if you have someone who's 40 years old with a wedge at 20, but their RV is huge and their PVR is high, I think that's not HFpEF in my mind. I think that's more group 1 PH or group 4, depending on what else they have. But if they're 70, their HF2-PEF score is really high, then I think those patients really do have HFpEF, and you have to be very cautious as you treat them because, again, they may not feel worse, but they may not feel any better either. That was a long way of saying I don't know.
That was a good answer. Miriam.
So I think it's worth also mentioning, Sean, what you think about people who have repaired mitral disease or repaired aortic disease, or your experience in those people who have mixed and they have like AS and like what you've done, because I think you've been pretty creative with that here.
Yeah, so I think there's been one major trial looking at post-valvular interventions in pulmonary hypertension, and that was the CEOVAC trial, not showing any benefit and maybe a signal for worsening heart failure symptoms. Again, I kind of take it at an individual level. I think if they have significant, if it's mitral stenosis, they have significant PVR elevation that doesn't improve despite your actual therapy of valve replacement. A trial, I think, is indicated if they're very, very limited, watching them closely. Aortic stenosis, I think there you have the kind of issues where, because a lot of these patients with severe aortic stenosis are also older, they have comorbidities, so they probably have underlying fibrosis in that left ventricle that even if you fix that valve, you're still going to have ongoing pulmonary hypertension. So I still treat them the same way, fix the valve, treat them with known therapies for HFpEF, and then if they still have ongoing PH with a high PVR, then trialing a PD-5 inhibitor if it's indicated.
Smart.
I have a question. Thank you, Sean. Great talk. So how do you use the exercise test for these patients, especially patients who have symptoms and then when you exercise them, they have a post-capillary pH?
Yeah. I think that's a great question. For the most part, when I see a patient in the cath lab, our biggest question is pretest probability of having HFpEF. And that's where your HFpEF score, very easy, this was at a Mayo Clinic, and you're looking at a couple of clinical variables. So if the wedge is normal, then I do exercise them to see what happens to their pulmonary capillary wedge pressure. I think you have to be careful when using exercise hemodynamics, especially interpretation, because they're not the cleanest data, and I'm sure everyone can attest to this. You see wide respiratory variations and things like that. I also do saline loading and leg lift as well before even starting exercise studies, because sometimes that can bore out if they do have some post-capillary left ventricular dysfunction, left atrial dysfunction.
And you would treat them just as HFpEF, but with all the regimen or something specific?
So I typically will start, so in talking about specifically in HFpEF, I think the biggest thing I try to start first are SGLT2 inhibitors. I think there's better data now with 2 large trials showing an improvement in not only hospitalizations, which for that patient who comes in, has left atrial hypertension and has the high wedge, they may not come to the hospital very often, they're just very dysmic, but you can see improvements in quality of life scores, KCCQ and things. So I can at least tell them that you might have an improvement in your actual symptom burden. So I start with that and then add medications as sort of tolerated.
Gustavo.
So that was a great talk. So the data for SGLT2 inhibitors seems pretty compelling. So I wonder, has that changed your threshold or at least your time frame to try PD5? In other words, a patient would have HFpEF where there's some features on the RV by echo, by PVR, perhaps a bit higher than you would like to see in a HFpEF patient. You may have tried a PD5, but now would you now do an SGLT2 inhibitor first and then see what happens, or that doesn't really factor into your decision?
Yeah, no, I think that's a great question. I think what I typically do first for our HFpEF patients are first control whatever I can. So I do start SGLT2s up front, MRAs if they're potassium tolerated, and then controlling other sort of things, including blood pressure, which can be very problematic in a lot of these patients, systemic blood pressure. And I think if you control all those things and they're still having symptoms, I think also this is expectation, right? I don't think you're going to get them, these patients who are true HFpEF with pulmonary hypertension, feeling like they're going to run a marathon. So I think some of this is going to be sort of shared expectation of what their goals are. But if they're not meeting their goals, then I think adding PD5s at that time. But I do give a trial of true medicine, like our heart failure therapies first. And if they're not improving, then I do trial PD5s.
All right, fantastic. Thank you so much, Sean. That was truly an eye-opening talk.